right, after that wonderful, wonderful talk, we have now Dr. Parag Patil, who is faculty here at University of Michigan. He's been here since 2005. He's affiliated with no less than 4 departments: neurological surgery, neurology, anesthesiology, and biomedical engineering. He has combined medical and doctoral studies in biomedical engineering. He obtained them from the Johns Hopkins University. His research during his residency at Duke University was featured in the Time magazine and was on the cover of the journal Neurosurgery. His research interests include brain-machine interface, neuroprosthetic devices, motor and cognitive human systems, and neuroscience mechanisms of deep brain stimulation. Today he's going to talk about the mind and the body approaching joy and suffering through neuromodulation.
I've also got a case of laryngitis, so this may prove to be a shorter talk than originally anticipated. I really enjoyed the previous talk, and it reminds me of a write-up that was done about how the speed of communication was creating stress in the world, and the need for responsiveness and the amount of information that we get, and how this is causing so much trouble. It was actually written by a Roman about 50 AD because the construction of highways in the empire suddenly increased the amount of information flow and so on. And so just when you think that Facebook is changing human nature, just remember it's been around for a long time, and you may not be quite as unique as you think. So I'm a neurosurgeon, and what that means is that I have a very physical approach to the brain, and I see how it impacts the mind. And so I wanted to talk about some of the therapies that we do and how they impact on this issue of mind and brain and joy and suffering. And, I'm no scholar of Vedanta, but I do enjoy reading. And one of my favorite quotes I came across is this, which is that knowledge can never be created. It can only be discovered. There is a reality out there. We don't know what it is. We may not even be thinking about it in the right way, but it's out there for us to discover. So we get these wonderful quotations from people who are wise. And I think that we have to ask ourselves sometimes, is this wisdom or is it absolute nonsense? And so we take a quote like this, which I think we heard just a few minutes ago. I am not the mind. I see that I am thinking. I am watching my mind act. And each day, the identification of yourself with thoughts and feelings will grow less until at last you can entirely separate yourself from the mind and actually know it to be apart from yourself. And you sit back and you think, what on earth is this person talking about? I separate myself from my mind. What on earth is that? I'm stepping outside of myself and examining myself. I mean, what is doing the stepping? What is doing the examining? Who is the observer and what is the observed? Well, I think one of the reasons that it's hard for us to get our heads around this, no pun intended, is that the mind is multifaceted. When we say mind, is there something that sits beyond ourselves? And, it can be built into a very profound question, do I extend beyond myself? And I would argue that it's actually a trivial question because the answer is, of course, I exist beyond myself. I have relationship to others. I engage in the universe and so on. But when we think about the mind, we can break it down into things that are more ourselves and less ourselves. And so maybe at the top is consciousness, this existence that we have, and then identity, self-awareness, personality is a little bit more automatic. Reflex, that's not, it's hot, my hand moves away from it. That's, not really me. There's movement, there's sensation, there's volition, calculation, language, memory, insight. And so there's this whole spectrum that is what it is to have mental experience. And the question is, how does that come about? Well, there's been this issue of what is the mind and what is the brain. And I fall in the category of people who believe that there's kind of a physical description, which is that the mind and the brain are one and the same. And what do I mean by that? Well, we want to be a little bit careful. And so one way to think about it is that the states and processes of the mind are identical to the states and processes of the brain. What that means is that mental experiences are brain processes. Now, I'm not saying that narrowly, like there's actually something in my brain and it doesn't include my spinal cord and it doesn't include the rest of my body. But what I would claim is that the mental experiences that we enjoy are physically instantiated in our nervous system, as opposed to, being a brain in a vat on Alpha Centauri and having things transmitted to our physical body. So with that caveat, and we may or may not agree with that, how do we think about the mind from the standpoint of the brain and the nervous system? Well, the idea is that you have neurons, there are about 30 billion of them, and these neurons form into circuits, and these circuits coalesce together to form the brain. So when we're talking about the mind in terms of the brain, we're talking about networks. So there's multiple ways of organizing these cells and these circuits that come together. And these networks may have different weights, and different experiences may arise through the activity of these networks and across these networks. But boy, that seems really hard. How do we go from, kind of a little speck of tissue firing impulses to this wonderful experience, which is what it is to be a somewhat depressed human being who's anxious and, trying to get tenure or having just gotten tenure and that sort of thing. And the answer is that there's this concept of emergence. And so what is emergence? Emergence is a phenomena whereby larger entities arise through interactions of smaller, simpler entities, such that the larger entities exhibit properties that the smaller or simpler entities do not. And so emergence is when the whole is greater than the sum of the parts. And we get lots of examples of this. And so we can think about friction. Friction is something we're all familiar with. It's not a property of the individual particles, but it's a property of them together. A hurricane, you have lots of wind, it comes together, forms something that has really substantial properties. A flock of birds, an ant colony, a city, all of these are larger entities that have processes or are built upon processes that don't have those properties. Consciousness, life, culture, and the mind. So the whole is greater than the sum of the parts. And so similarly, the mind arises from the nervous system because the whole is more than the sum of the parts. Now, there's another part to this that's kind of tough, and philosophers call it qualia. And qualia is what it's like to experience something. So it's the way it feels to have a mental experience, the way it feels to be sad, the way it feels to see something red or smell a rose or whatever. And people think a lot about this because qualia is something that is really hard to convey to someone else. I can't tell you that the redness that I experience when I'm looking at a sweater is the same redness that you experience when you're looking at the same sweater, and yet at the same time there's something that we all call red and we kind of know what we're talking about. And so there are these properties of qualia. And the reason to talk about these relatively abstract terms of emergence and qualia is that it's absolutely critical to what we try to do in the medical world in terms of treating our patients, because all of our patients are minds and brains and so on. And so the field that I'm involved in terms of treating patients is something called neuromodulation. And what is neuromodulation? Neuromodulation is changing the way that one sees and experiences the world through technology that alters communication in the nervous system. And the question is, are we up for it? Well, when we're thinking about technology changing our experiences, there are some things that we end up being much more comfortable about changing, and there are other things that we're very uncomfortable about changing. And so there's this kind of spectrum of decreasing comfort. Well, if I have a problem with my movement, and I'm going to show you some examples of that, I'm pretty comfortable with having technology to help me move normally. Sensation is also something that, maybe if I'm seeing the world in a strange way, I'd like something to change the way I sense things. Habits, we all have bad habits. We're trying to get rid of them. I think we'd welcome technology that helped us, stop Googling or something like that. Mood is getting a little bit more difficult because mood is a little closer to who we are. Memories, we all have memories. We want to have memories, but there are other memories that we want to lose. And how do those get controlled? If you could suddenly remember everything, is that going to make you happier in your life or not? And then finally, we have a sense of personal identity. Who we are as a person is a thought, is a mental experience. And that mental experience is instantiated in the brain. If I were to tell you that you can have a stroke or a lesion and it will eliminate your sense of who you are, I think we'd find that quite horrifying. Or if I told you that there was a technology that could be placed into the nervous system or into the room that would alter your sense of who you are, I think you'd also find that quite horrifying. So I have to ask you as a group, what is your comfort level? So how many of you, raise your hands please, would change the way you see and experience the world through technology? Who would take on that capability? Who would do that? Okay, a few of you would. The answer is that actually all of us do all the time, right? We take technology and we use it to alter our view of the world. And so it becomes critically important to understand what it is that we're doing and why we're doing it. And so I would claim that everyone in this room is an expert in neuromodulation. Now, there are different types of neuromodulation. There's chemical neuromodulation, whether people are changing their experience through taking medications or drinking coffee in the morning or having a beer or whatever. There are very important behavioral neuromodulations. When we talk about meditation, what is meditation? Well, I'm no expert on meditation, but my experience of it is that meditation is an exercise that helps us to focus our attention or to become more aware of where our attention is going. We engage in therapy, whether it's cognitive behavioral therapy or other forms of therapy, and that helps us to change the way we think. Like the previous speaker said, it's not that you're consciously aware of how you think and therefore changing the way you think. But in fact, the practice of being kind to yourself allows you to be kind to others. The activity of being critical of your own self-talk, about being aware of what you're saying to yourself, makes you more aware of how you speak to others, and vice versa. If you're careful with how you speak to others, you'll be more careful with how you speak to yourself. And finally, we do things like go running because it feels good. It helps us feel alive. We feel active. And so we're modulating our nervous system through these behaviors. Well, as a neurosurgeon, I do electrical neuromodulation. And there are different ways to modulate the nervous system. Usually This involves putting electrodes in different areas. It might be on a peripheral nerve, such as the vagus nerve, to control things like seizures. It might be tingling sensations due to a TENS unit on the skin, which alters pain. Spinal neuromodulation is an important way to treat things like back pain and lower extremity pain. And finally, there's deep brain stimulation. All of this comes together into a field which is called functional neurosurgery, where we treat diseases where the MRI, the structural components of the nervous system, are largely normal, but there's something that's going wrong. And some of the areas that we look at are things like movement disorders or pain or tumors or epilepsy. And so I kind of want to give you some examples of this. So when we think about disorders of movement, there's one kind of quintessential example, which is Parkinson's disease. On the left-hand side, you see the dark black matter of the substantia nigra. This is polymerized dopamine, which is one of the chemicals of the brain. And in Parkinson's disease, the cells that make that dopamine die. And so you see on the right-hand side an image where you don't see that black matter. What is that like for people? Well, this is one of my patients, and this is how he is all the time. So you can imagine how difficult it is to go to a restaurant, to carry on a conversation, to be in conversation with him when he's doing this. And this has been a problem for ages. Surgeons had tools of increasing sophistication over time to deal with this problem. In Victor Horsley, around the turn of the 20th century, reasoned that, well, maybe one way to take care of these tremors is to open up the brain and to lop out the part of the brain that is responsible for movement, and maybe that'll improve tremor, and it did. Earl Walker, who is an American, reasoned that the pathways for this movement could be cut, so it was like cutting a wire. And as time went on, we developed more and more sophisticated ways of less invasively introducing changes into the brain to address these kinds of tremor. So for a long time, the way tremor was treated was to create a little stroke. You can see that little bright spot on the left-hand side of the screen, which is the right-hand side of the brain. Doctors do these kinds of things to keep us having job security. You know, we flip things around, and so that in ways that only we understand. But the idea is that you can create a lesion and eliminate tremor. And that's really exciting, and patients really enjoy the benefits of this kind of treatment. Deep brain stimulation evolved out of these lesions. And how many of you have ever heard of deep brain stimulation, by the way? Okay, good. So deep brain stimulation has been around a long time. It was first tried in the late 40s, essentially as a way of having chronic stimulation to alter this tuning of these circuits in the brain. And the only reason that it didn't catch on in the 1950s is the computational power that was required would probably fill up this room at that time. And so it was hard to walk around with a tractor trailer with a big computer behind you. But as technology evolved, the processors became miniaturized, and when pacemaker technology was introduced in the 70s, people started doing deep brain stimulation first for pain and then for movement disorders. And so about once a week, I will do a surgery in which I place a deep brain stimulator into a patient for movement disorders. And this is a pretty straightforward technology. It's a lead. You can see on the right-hand side, there are 4 contacts on each lead. We place them in specific locations in the brain to give you some sense of size. Each of those little contacts, of which there are 4, is about 1 millimeter on a side. And so we need to hit something about the size of a peanut in the middle of the brain to make this whole thing work. And so let's take a look at that patient again to get a sense of how deep brain stimulation works. And you can see the effect in the appropriate patient of a well-placed lead can be quite profound. So the question becomes, how does deep brain stimulation work? And the answer is that it tunes the circuits of the brain in a way that creates order where there was disorder. It modulates information flow, and it induces plasticity. So some effects of deep brain stimulation are immediate, and some effects take time to develop. So I wanted to show you an example of another disease called dystonia. Dystonia is what you'll see. So these are patients who have abnormal co-contraction of opposing muscle groups. They're not able to move normally because of this effect, and we associate this with cerebral palsy. What I'd like you all to leave knowing is that many of these patients have completely normal thinking, and in fact, they're trapped inside their bodies. The beauty of DBS is that in this particular disease, the improvements are quite profound. This is the same patient a couple of weeks after surgery, and that over time, the benefits are maintained, and in fact, in this particular disease, they improve. So one might wonder, how does this all work? And I mean, I'd love to talk to you later about the ways we can figure out how they work, but one is called functional neuroimaging, where we can look for changes in the activity of the brain. And when we have this stimulation, when we don't have this stimulation. And so the question becomes, well, what makes this hard to do? And the challenge really is that we're all different. This is University of Michigan graduation. You can see there are a lot of graduates there. Each of them has a face. Each face is different. Our brains and our minds are the same way. We each have a brain. Each brain is physically different. We each have a mind. The mind is different. And so therefore, when we're treating things, something simple like tremor, which seems to be relatively stereotyped, is easy. But something complicated like depression, obsessive compulsive disorder, schizophrenia, or addiction requires a higher level of sophistication than what we have. We have some tools that we're now understanding the brain better. This is some research that's being done in my lab, and the only thing that's important is that we can take little gray blobs like you see here, which is an area of the brain called the thalamus, and using very fancy MRI technology called diffusion tensor imaging, we can segment that thalamus into functional areas. What that ability to segment the thalamus does is it allows us to appreciate the individual diversity that occurs on the structural level and explain differences in individual outcomes for our therapy. This is all a prologue to tackle something really difficult, which is, so far I've showed you disorders of movement. The question is, can we also address disorders of the mind? That mind that we're trying to step outside of and look at, that nonsense that Vivekananda was talking about that I simply don't understand. Well, disorders of the mind are a big problem for humankind. And treatment-resistant depression is common, it's severe, and it's dangerous. So depression occurs in about 2.6% to 5.5% of men and 6 to 11% of women. There are 340 million people worldwide. That's the population of the United States. And there are 18 million in the United States itself. What's really tragic is that between a third and a half of patients fail to respond to the therapies that we have. The good news is that the therapies that we have for depression are ridiculously simple-minded, and so it's a miracle that they work at all. Depression has been around for a long time. Aristotle actually had a very good description for it, which describes our common experience. You know, we all often are in the condition of feeling grief without being able to ascribe any cause to it. Such feeling occurs to a slight degree in everyone, but those who are thoroughly possessed by them acquire them as a permanent part of their nature. That is what it is to be depressed. Even Aristotle could see that. We've been trying to treat depression for a long time, both medically and surgery. We've tried things like opium and alcohol and St. John's wort. We've even tried fish that are electric so that they create a shock when we put it on the face or on the head. And we've tried various surgical therapies. This is actually a skull from about 2000 BC. And amazingly, what we see as primitive surgeries resulted in survival rates of 80%, and clearly they thought something was being done. Now, I will note that modern neurosurgery had a fatality rate of 30% turn of the 20th century. So in 2000 BC to, the 20th century, we really didn't make a lot of progress, but fortunately there's been more. Medieval times, surgery was also used. The idea was to let evil humors escape. We laugh when we hear theories like letting evil humors escape by putting holes into things. But similarly, people 100 years from now will be laughing at us for the theories that we hold to be true regarding medicine. Most of us have heard of surgery for depression. We saw One Who Flew Over the Cuckoo's Nest, and we know who this man on the left is. It's Walter Freeman. He was a neurologist. He wanted to address the problem of depression at a time before there were medications, and he had a surgery called a frontal lobotomy, which was effective in some patients, and he thought it could be effective in many patients and kind of went rogue. With new technology, we have new approaches, and what we can look at with PET, which is a type of imaging which looks at the activity of certain chemicals in the brain, is that there are changes in specific areas of the brain that are associated with negative affect or negative mood. So that when someone is depressed and is treated, that activity in that area of the brain changes. When someone is happy versus being sad, that same area changes. And when that person has kind of transient, tragic thoughts, areas of that brain change. And so the thought was that perhaps we could take one of these deep brain stimulators and place it in that area, change the activity in the brain, and have a positive effect. Now that actually was kind of genius, but it was also kind of foolish. And let me tell you an analogy. So I'm driving down the road and I notice that my car stops. I recognize that there's this thing that starts at E and goes to F. And when it's at F, the car runs, and when it's at E, the car stops. And so I notice this is very consistent. So I reason that the way that I'm going to get my car to start next time it goes from F to E is to break the glass and to shift that pointer from E to F, because surely then the car will be able to run. So by changing the activity in one area of the brain, we may believe that we're going to have the behavioral outcome that we want, but we may be no more clever than the person who tries to shift their fuel gauge. By the way, nowadays we don't even have the fuel gauge, so it's some digital thing. So, but nonetheless, a trial was attempted where deep brain stimulator leads were placed. The details of the trial aren't that important. The leads were targeted according to this area of stimulation, and what we saw was quite amazing, that in PET studies, we saw that when we turned on the stimulator, we saw changes in activity which were similar to changes that occurred when patients did not have depression any longer. And so there was an initial study done. I actually wasn't part of that initial study, but it was part of the later studies, where 4 out of 6 of the first patients showed significant reductions in depression. We had found a way to modulate the mind by treating the brain. A second study was done with 21 patients. This was an open label study, which means that the patients were aware of whether their stimulators were on or off and so on. And there was this very nice reduction in depression with the presence of deep brain stimulation. The next step was to do a randomized sham-controlled trial. This is where patients have surgery, but their stimulators are not turned on, or they are turned on, and their mood is monitored over time. And what one does is tries to compare the patients without the stimulator on with the patients with the stimulator on and see what happened. Well, you can see that the 2 lines pretty much were parallel, which means that there was absolutely no clinical effect. So why did this happen? Deep brain stimulation had so much promise in the open label form, but didn't succeed in meeting its endpoint in the blinded trial. So the sources of failure are actually many. One is patient selection. Depression is not a homogeneous disease, just like we are not homogeneous people. And perhaps it was some patients with one type of depression were treated effectively and others weren't. Second is timing. So the trial was for a finite duration of time, and it turns out that the patients with stimulation continued, just like the patients with dystonia, continued to have benefit over time and increasing benefit over time. And maybe the trial just stopped too soon. And finally, there was targeting issues. So we put the leads where we thought they should go, but everyone has a slightly different brain. And so some patients had structural differences between their brains, and we may have just ended up off target for them. So just to wrap up, wisdom or nonsense? This stuff about neuromodulation, Vedanta, whatever you want to call it. Well, the fact is that we access our minds or our brains through multiple mechanisms. Some of them are physical, some of them are volitional, meaning that we're aware of them and we're imposing them on our minds, and some of them are simply unconscious. We have no idea that these things are occurring, and yet they are all the time. We're able to do neuromodulation, whether it's chemical, behavior, or electrical, and this tunes the relationship between the brain and the mind, sometimes in ways that we understand, sometimes in ways that we don't. As we better understand this relationship between mind and brain, as we better understand emergent phenomena, how it is that these neurons come together to form circuits, to form larger circuits that give rise to things like consciousness, we'll be better able to modulate them and be more successful in treating disease. And finally, the true challenge lies in uncovering the nature of these illnesses, what really is going on inside the brain, and the commonalities between us, because it's the things that we share that allow us to develop therapies that are useful for many. But also we have to appreciate the neurologic basis of our individuality, because one size does not fit all. It doesn't even fit many. And so as we come to understand these things better, we'll be able to develop better theories, better treatments, whether they take a more invasive form or a less invasive form. And go blue.
Dr. Patil, I was wondering could you explain the hard problem of consciousness as you see it, and you know how you would possibly, you know.
That's like explain God in 10 steps. You know, I mean, so consciousness, I mean, first of all, consciousness is lots of different things, right? When we're awake versus we're asleep, whether we're aware versus we're unaware, whether we're attentive versus unattentive, and that experience of being able to experience. I think what's fascinating about consciousness is that, you know, when we think about it structurally, it arises in the cortex, but there are lots of animals that don't have the kind of cortex that we have that also seem to manifest different types of consciousness. And so there's this concept of blind sight. I don't know, who's heard of blind sight? Okay, so the way blind sight works is that essentially you can take people who have the area of their brain responsible for vision and it's had a large stroke. So they are not able to see anything. The world appears black to them. However, if you throw a ball at their face, they'll reach up and they'll catch it. Why does that happen? It's because there are processes that are occurring below our conscious level that are still able to function when areas of our brain are destroyed. And so we are building tools to understand those kinds of underlying processes more and more. And so the question is not to find an explanation of consciousness. The question is to find a description of what consciousness is that we can then probe the brain to figure out.
Hello. So you mentioned 3 types of modulations: chemical, behavioral, and electrical. So are these related? Like what I'm trying to ask is some sort of a behavior triggers some chemical, which in turn triggers some electrical. So that's one question. And the second question is, so we have a lot of things which say that this is heart healthy, etc., healthy eating, whatever. So do you have anything which keeps the brain healthy over the long time? I mean, I haven't heard of anything which says this is brain healthy. So is anything happening on those?
I got the first part of the question. The second part of the question, could you?
Okay,
repeat?
so I'll frame it in a better way. Like, is there anything understood about how to keep the brain healthy over a long time?
Yeah. Okay. So the answer is absolutely chemical modulation, behavioral modulation, electrical modulation. All of these things are acting on the same brain circuits. They're just addressing them in different ways. I mean, I personally would advocate a less invasive, more natural way, and I think meditation is wonderful. I think that, I mean, it's something that I advocate for a lot of my patients, particularly those who have anxiety kinds of disorders. It's enormously helpful, and so on. I think that sometimes when meditation isn't helping, that maybe a little bit of pharmacology can help you get started and set up those circuits working in the right direction. And for those for whom they have depression of the sort that their own efforts are not working, medicine is also not working, then something invasive like deep brain stimulation can be considered. So all of these things are acting on the same circuits of the brain. The second part of the question is I'm not sure I can really address that because it's a tough one.
It would seem that for many individuals, depression or other mental illness like schizophrenia is very instantiated. It's long-standing, but you have to consider that for most of these conditions, they start occurring at a certain point in adolescence or young adulthood. So it tests the idea of whether there's something that's truly different about the person anatomically and genetically, or whether the condition they have is emergent, just part of the circuitry. And so holding in mind that these kinds of mental states start occurring at a certain point, does that change one's approach towards them?
So that's a great question, and it has a number of different components. So the first is, are there mental states that are possible later in development that aren't possible early in development? And we know that at a simple level, that's true. So for example, children don't have myelination in certain parts of their brain. So there isn't insulation on the wires. And it turns out that the rates of myelination correspond very well with the rates of use of those kinds of capacities. And so on the one level, there certainly are physiologic phenomena that impact on behavior. But this tuning of the circuits of the brain is also important. If we have a severe traumatic experience, even if we don't remember it sometime in childhood, maybe that also impacts how we respond to things later in adulthood, things like post-traumatic stress disorder and so on. Patients or people or all of us have the experience of something having a profound impact on us, and we're not sure why. And so one of the things that meditation or other tools may help us get more sense of is what the relationship is between our behaviors and their antecedent causes. But it's a great question. So then the question becomes, well, how do we tune these things? Well, it depends, because maybe what antidepressants are doing, for example, is simply changing the weighting of some of these circuits in a way that is helpful towards developing more healthy patterns of happiness. But at the same time, if you looked at that book, I forget what it's called, something Prozac. We might be medicating ourselves to become more the person we want to be instead of the person who we actually are. We have to be aware of that as well.
Hi, thanks for the wonderful talk. So I guess my question is like, how do you exactly define consciousness? So, for example, if I am reacting to an external stimuli, is that consciousness, or I'm feeling like, happy, or I'm feeling sorrow? Is that consciousness? What's the neurological definition of consciousness?
I don't know that there is a specific neurologic definition of consciousness. What I would suggest is that consciousness is a spectrum, that there are things that we're very aware of, and then there are things that we are unaware of. So consciousness, in the sense of being conscious of something, is the degree to which we're aware of it, this qualia component. But there are other definitions of consciousness which might have to do with our ability to have impact on something. So I don't know that the question of what is consciousness actually becomes such an interesting question. I think that what is more maybe relevant is what are those aspects of consciousness that we can impact on in a way that allows us to enjoy the experience of being alive better.
Thank you. You mentioned plasticity in one of your slides, and I'm wondering what you think about this phenomenon of games like Lumosity and so on, and some of the claims they make about helping develop or increase plasticity. Do you think that's a good method to use for that?
That stuff is awesome. So we had this lecture, and by a very famous neuroscientist from San Francisco, who said, this random white noise generation actually increases the amount of randomness in neural circuitry and creates a disorder. And so I instantly called up my brother, who had just had children. I was like, turn off the white noise generator. You don't want that in the room with the kids. And they were just like, oh. So, I mean, I definitely think that things like that Lumosity is working on, white noise, Sudoku, all these things are known to help us create patterning in the brain, which can be useful. If you are developing Alzheimer's disease, the activity of using those circuits is helpful. If you have a stroke, you go to physical therapy because the activity of using those circuits is helpful. And so I think there's definitely a real utility to these things. What's hard is that experience is actually multidimensional. And so simply focusing on one particular vector of development might leave out all of the other things you need around that. In the same way that, if I put something in the brain that makes you feel happy, that's not going to make your life better because all of the other things around you are not moving coherently in that direction, which is why drugs don't work. Yeah.
So with regards to chemical modulation, neuromodulation, I was wondering. So does the food we eat have an effect on our moods, our ability to? I mean, for instance, food with high antioxidant content. I read something about the relationship between antioxidants and free radicals. I'm not a medical student, so I'm not sure about it. But that's something I was curious about.
Yeah. So the whole relationship between nutritional supplements, antioxidants, and so on. I mean, what we know is we understand how antioxidants change things at a chemical level, right? I mean, it's simply oxidation of certain molecules and how it changes their function. How that then bridges to everything else is a lot murkier. I think that in the end, just like any other medication, you can take an antioxidant, you may reduce the level of oxidation. Take vitamin C, right? We all take vitamin C when we're getting sick and stuff like that, and we all think that it helps us, and maybe it does. But understanding then what the connection is to the antioxidant and say something like memory is a lot of steps that we don't understand. No. One of the best things about being a neurosurgeon is that I'm a neurosurgeon, and then I can really confidently say, you know what, I have no idea. Thank you.